Physiology, fast acidosis, alkalosis, the normal values you have to remember: pH normal 7.35 to 7.45, PCO2 4.5 to 6, bicarbonates 22 28, base excess generally +2 -2, it's like this. Then PO2 10 to 14. So what is respiratory acidosis? Whenever there is retention of carbon dioxide in the body, that increases forms the carbonic acid, leading to respiratory acidosis. When hypotension, hypoventilation is there, either because of morphine poisoning or overdose of morphine or COPD, the person takes a respiration, slow respirations, and that is called as respiratory acidosis. In this, what is the values of pH will be in acidosis will be less, and carbon dioxide will be increased, PCO2 will be higher. Uncompensated means it is not compensated with the carbonate levels, so bicarbonate levels will be normal. When bicarbonate level increase, it means they are trying to compensate. So this is compensated. So what is respiratory alkalosis? Whenever there is hyperventilation, so carbon dioxide is washed out, trying to wash out from the body, a respiratory center is stimulated to increase because of hypoxia, and there is person is hyperventilating. So that leads to increase respiratory alkalosis, decrease partial pressure of carbon dioxide, and if it is uncompensated, it means bicarbonates are normal. If it is compensated, it means bicarbonate going to dip. Metabolic, basically it occurs because of metabolic acidosis. Any of the cause may be diarrhea or high output fistula. Here the alkalis are lost, bicarbonates are lost from the body. Addison's disease, peritonitis, where the bicarbonates are lost, and this leads to metabolic acidosis, increase in pH, increase in hydrogen ion concentration, decrease in bicarbonates, and it is compensated by the respiratory mechanisms. In ABG you get the values like low pH, low bicarbonate, and by respiratory mechanism your body is trying to compensate. So partial pressure of carbon dioxide will be normal. In uncompensated, it will go down if it is compensated. In alkalosis, when the person is vomiting a lot of acids, CHPS, gastric outlet obstruction, Conn syndrome where there is retention of sodium and water inside, and Cushing syndrome, all this leads to alkalosis. Nasogastric tube in the ICU patients, when you put it, lot of hydrochloric acid is lost, that leads to increase pH, that leads to alkalosis. And so pH is increased, bicarbonates are increased in the body. And if PCO2, now PCO2 compensatory mechanism, when metabolic cause is there, it is with the help of carbon dioxide. If it is respiratory, is there compensated by the bicarbonates. So if PCO2 is raised, it means body is trying to compensate by retaining carbon dioxide. So in COPD, ABG shows increase of carbon dioxide. So whenever patient is having COPD, APG shows increased carbon dioxide. So COPD patient has got CO2 increased, and compensatory, what is that? If CO2 increase means there has to be a respiratory acidosis. Respiratory acidosis. Then to compensate it, bicarbonates will be increased, compensatory. So this is the case in chronic COPD. So you get raised carbon dioxide as well as bicarbonates. So this is about respiratory compensatory. Now coming to metabolic acidosis. What is anion gap? It is the total of cations plus anions. Sodium and potassium cations, anions, bicarbonate, chloride. It is around 10 to 18. This is to be 10 to 18. So normal anion ion is hyperchloremic. Whenever chlorine is given, we have to find out normally hyperchloremic. So what are the causes of metabolic acidosis? This is loss of bicarbonate. HCO3 is lost, and this is gain of hydrogen. high acids, loss of bicarbonates. Bicarbonates loss in the body from the renal tubular acidosis, Addison's disease, it is Ragada miles, Ragada piles, Ragada mud piles. RAGHDA. R is renal tubular acidosis, A is Addison's disease, GIT, loss of the bicarbonates as diarrhea, fistula, hyperinfusion of the saline. More the saline is given, drugs like acetazolamine, ammonium chloride injections. Then mud piles, MUD, methanol, uremia, diabetic ketoacidosis, paraldehyde, INH, lactic, sepsis, ethanol, salicylates, mud piles. So this loses bicarbonates, this loses acids. Now this is the important, what is the daily requirement of sodium and potassium? Sodium is 1 to 2, potassium is 1.5 to 1 to 70 kg man, 70. Hypokalemia, loss of potassium is seen in rectal adenoma, secreted diarrhea, fistula, vomiting, all the conditions where potassium is lost, that is hypokalemia. Clinical picture will be again classical arrhythmias, ECG, you have no P, no T, but long PR and long QT intervals, paralytic ileus. And treatment is just supplementation of potassium, mild, moderate, severe, depends upon. If severe, give IV vitamin, IV potassium, Kesol. So moderate, you can give oral, then deficit. Hyperkalemia, this is important. So hyperkalemia can be in this manner. It is there, the ECG findings will be cardiac arrhythmias. Just you see cardiac arrhythmias, ECG will have flat B. There is a pull effect. T wave will be wide, abdominal cramps, skeletal muscle weakness. So it depends upon how is it. It is severe, mild, moderate. Then if you go for severe hyperkalemia, more than 6.5. So moderate hyperkalemia, severe is more than 6. Moderate with ECG changes, stabilized heart by IV calcium gluconate. First is calcium gluconate. Then the dialysis there, moderate hyperkalemia, IV glucose with salbutamol is used, chelating agent is used, and mild 5.5 to 6. Treatment of the cause. It's just you see the table, and angiotensin blocker and beta blockers, drugs like hypertension causes hyperkalemia. Difference in angiotensin blocker decreases sodium also, while beta blocker does not. Quick reference of the emergency hyperkalemia in the adults. You see, assess the patient with ABCD approach. 12 ECG has to be done. You get more than 6. Then pseudo hyperkalemia, empirical treatment for arrhythmia. Mild it is less than 5.5 to 9. Moderate is 6 to 6.4, and severe is more than 6.5. So if you see severe and some ECG changes in that, if you see tall T waves and all that, you have to go for control by giving 30 ml of calcium gluconate. Use large bore IV and administration, and watch for ECG changes. If it recovers back, it's okay. If not, then give glucose IV infusion. Then again see whether it covers or not. Give salbutamol, calcium resonate, diuretics, sodium bicarbonate, or hemodialysis. Dietary restriction of the potassium is required if suppose it is moderate. So this is about hydrate. Then important ion cation is calcium. Now hypocalcemia is most of the time seen in post-thyroidectomy, acute pancreatitis, respiratory alkali decrease, and magnesium deficiency. Latent tetany, Chostek sign and Tozish sign are there. Manifest perioral numbness, muscle cramps, convulsions, carpopedal spasm. This has got prolonged QT interval because calcium is a excitatory ion, so this increases the QT interval. The treatment is by 10-10-10 formula. Calcium gluconate has to be given. Here the calcium gluconate was not 10-10-10. Here it is 30 ml calcium gluconate for hyperkalemia, but here you give 10-10-10 calcium gluconate. This is for hypocalcemia. That is for hyperkalemia. There you get 30 ml. So this will be given in glucose. So now what is hypercalcemia? Increase, it may be increase in metastasis, it may be hyperparathyroidism, sarcoidosis, milk alkali syndrome. This can increase, elevated about 2.5. Adjusted calcium has to be there. It has to be adjusted with protein bound, disease of the bones, stones, groans, and psychic bonds. It shortens the interval. Now treatment is, now what is there? There is increased calcium. Again the treatment is 4 to 6 liters of normal saline is, you have to start with saline, first line of treatment. Then you bisphosphonates, pamidronate, potent, zolidronate you have to give, and calcitonin is the quickest action, prednisolone for sarcoidosis, and sodium bicarbonates. So whenever there is increased calcium, hypercalcemia. What is patient's calcium level? Reference adjusted serum calcium level, 10 gram of calcium gluconate. Hypocalcemia, this is about calcium. Magnesium level, now just go for the magnesium. It is largest store in the skeleton, not in muscles. Then it is muscles. Causes of hypocalcemia is very much reduced intake, that is anorexia, malabsorption, excessive losses in diarrhea, ketoacidosis, ammonia, amphotericin, cyclosines, all these. Clinical picture is if it is less than 0.5 millimoles per liter. Anorexia, nausea, confusion, weakness, ataxia, paresthesia, tetany, all these are the clinical features. Cardiac arrhythmia present. So magnesium leads to same symptoms like calcium. Chlorides, low chloride, vomiting, CHPS, gastric outlet obstruction, hyperchloremic, hypocalemic, metabolic alkalosis with peroxidical aciduria. This is the mean. High chloride, unidiversion ileal conduit may lead to hypocalemic metabolic acidosis. Excess saline given may lead to now hyponatremia. So check serum osmolality, it is normal or what. I'm not going to again go for this. Syndrome of inappropriate antidiuretic hormone. What happens in this? It is antidiuretic hormone which is inappropriate, where it happens SIDH, either in CNS, traumatic brain injury, brain infections, pulmonary disorders, ARDS, pneumonia, anything, small cell cancer, brain tumors, malignancy, paraneoplastic syndrome, drugs like antidepressant, antipsychotic, antiepileptic, antibiotics, antidiabetics, or chemotherapy, and all these drugs may lead to SIDH, antidiuretic hormone secretion. What is the clinical picture? Antidiuretic hormone, it retains the water with the sodium. Along with that, symptomatic, if it is mild, moderate, and severe. So it retains more water, so there is hemodilution. So it retains the sodium, but sodium as compared to that, the water is retained, and that leads to hemodilution, mild. So you measure the serum osmolality. Mild when the sodium content is less, severe it becomes less than seizures, convulsions. So you think it is causing antidiuretic hormone is retaining sodium, how it is increasing, but more water is retaining, and that is causing hyponatremia. While more sodium compared to that is lost, so osmolality of urine is increased. So when you see this, acute within 40 hours, chronic euvolemia, no signs of dehydration, decreased plasma sodium and osmolality. Urine sodium is increased and osmolality is also increased. This is a typical feature. More water is absorbed, is retained as compared to sodium. So there is hyponatremia, and you see in urine there will be hypernatremia, increase. So treatment of the cause, fluid restriction, you have to restrict the fluids. Hypertonic saline is given in this. You give normal saline. Not normal saline, hypertonic 3% if acute. Vasopressin antagonist, talbopatine. This is ADH antagonist. So rhabdomyolysis, what happens? There is a crush injury, compartment syndrome, marathon runner, all these causes muscle pains, abnormal raise in muscles, runners, muscle abdominal color of the urine, increased creatinine kinase. This is more increase, and myoglobin, hyperkalemia. Complications, acute tubular necrosis, kidney, sudden cardiac arrest, severe hypokalemia, protect the heart first and may need IV calcium gluconate. Tumor lysis syndrome after chemotherapy, after high proliferative tumor, Burkitt lymphoma and all this may lead to tumor lysis syndrome. Arrhythmias, acute kidney injury, increased urinary acids, hyperkalemia, hypophosphatemia, hypocalcemia. So treatment is hydration is required. Now this is again about the fluid compartment. Total body fluid is 42 liters, intracellular is 28 liters, 60, 40, extracellular is 20, interstitial is 15, this like this, 60, 40, 20, 15, 5. This is intracellular fluid, this is total extracellular fluid. This extracellular, this is interstitial, and this is around plasma. IV fluid causes increase glucose or saline. Eat free fluid in extracellular fluid. Saline increase extra fluid only with same osmolality, but glucose is hypoosmolar, and hypotonic also, while saline is no isotonic. Normal osmolarity is normal. Fluid in the interstitial fluid compartment. So when it enters into interstitial fluid compartment, that leads to edema due to burn by hypothalemia and inflammation, hypoalbuminemia, and inflammation due to increased permeability. So what are the important hormones and electrolytes? Cushing syndromes, there is increased sodium and water. So I will just finish this. Cushing syndrome, Conn syndrome, you can see this figure, what is there, CONN. So what you have to do is to think of that sodium is retained more. And Addison's disease, in Cushing's and Conn, it is same. So Cushing's on is same, Addison is totally opposite, sodium is lost in Addison's disease. So hyponatremia, Addison's crisis, hypotension, causes postoperative pigmentation, all this is there. Syndrome of inappropriate antidiuretic, water absorption, dilution, diabetes, water absorption. Urinary sodium will be less.